At the outset, I would like to thank Srinivas and his team for the kind invitation, and it's always great to be back in Hyderabad. It's amazing to see how your city keeps on progressing and widening out, stretching out of the limits all the time and becoming bigger and bigger. So, over the next 15-20 minutes or so, we are going to talk about approach to a patient who comes in shock. And obviously, when we sort of start thinking of shock, there has to be a definition that what does shock mean. Shock is defined essentially as a state of cellular and tissue hypoxia, which is either there due to reduced oxygen delivery or increased oxygen consumption or an inadequate oxygen utilization. Essentially, the cells are deprived of oxygen and nutrients, and because of which the metabolism starts failing off, which is what we define as a clinical state of shock. The most important thing to understand is that shock is a life-threatening condition which more often than not presents with hypotension, but not necessarily. Okay? So, hypotension can be one of the features of shock, but it is not always the cardinal rule that the shock has to come with hypotension. Okay. It can also present with some other vital signs which may be abnormal. For example, you may just have tachycardia, resting tachycardia, and that may still be a state where you will have to go and dig it out and find out what is the reason for this patient's tachycardia, and you may be surprised to know that patient is actually in shock. And other thing which we know of is some parameters like lactate, for example, and increasing lactate is a known phenomena in patients who come in with shock, and there is a lot which has been talked about, and over the next day or so I am sure you will be keeping on hearing about lactate. In fact, in both my talks, this one and the one which is going to come after 2 or 3 lectures in between, I am going to talk a little bit about lactate in both the talks. So, lactate seems to be the mantra that everybody wants to know what is the lactate of the patient. The problem is when you do not know the origin of the shock, which we call often as an undifferentiated shock, and the situation is that you have a patient who has come to you and you are now trying to find out what is the cause of this patient's shock. That is when an approach towards shock is important. Okay. A patient comes to you with trauma and you have blood oozing out from 2 or 3 sides. It is not difficult to understand that this patient has got a hypovolemic shock because of bleeding. But when he comes in with subtle signs, or when he comes in with no obvious signs of where the shock is coming from, that is when you start thinking what type of shock am I dealing with? Am I dealing with shock or am I dealing with something else? No matter what the cause is, the pathophysiology of shock still remains the same. You have an inadequate perfusion initially, which then leads to tissue hypoxemia or the cellular hypoxemia, then leads to energy deficit. To recover that energy deficit, you have lactic acidosis which sort of picks in because of the anaerobic metabolism which starts up, and then the anaerobic metabolism and the metabolic acidosis gives out a parallel branch which is what we call as a metabolic acidosis giving rise to vasoconstriction, and then it becomes a vicious cycle. You have more hypoxemia, you have more cellular membrane dysfunction, you have your potassium and the sodium pumps which gets altered out, and you have toxic substances which enter into the circulation, and then the vicious cycle just keeps on repeating itself. So, essentially what happens is that if you do not reverse the process, or if you do not try and help out the patient very quickly, you are going to land up in a situation where very soon this will become a decompensated and then it will become an irreversible situation. Okay. So, it is only going to give you a finite amount of time where you have to act and where you have to actually try and find out the etiology. Gone are the days when we would be taught in our medical school, warm hand, cold feet, warm peripheries, this looks like a cardiac shock, this looks like a septic shock. Gone are the days. Okay. Now we have more of a syndromic approach towards everything. Okay. Everything is syndromic. Even if you talk about simple sepsis, the infectious disease guys and the intensive care guys, we always talk about what is the syndrome. Am I dealing with a genitourinary tract infection? Am I dealing with a pulmonary syndrome? Am I dealing with some other blood-borne infection? So, everything has to have a syndromic approach. So, similarly, shock has to have a syndromic approach. Where are we dealing with this problem from? So, if we think of it in that way, your understanding of the situation becomes easier. Of course, this is human body, you will have an overlap. Nothing is going to be black and white that you will only have a cardiac shock and you will not have a septic shock to go with that. No, you will always have overlap of two. But if you try and do a syndromic approach, you will have a little bit better of where we are. Classically, the shock has been sort of categorized into the distributive shock, which is, again can be sort of categorized into either septic shock, where you have a peripheral vasodilatation and then cause shock coming into the picture, or you have a non-septic etiology as well, like an inflammatory shock, for example. We all are aware of the cardiogenic shock. Again, in cardiogenic shock, you have cardiogenic shock because of the poor contractility, or you may have a cardiogenic shock because of arrhythmias, or you may have a mechanical shock because of the cardiac problem, like an acute valvular lesion, okay, or a large regurgitant lesion which has been there for some time, and now it has come to a point where the patient is starting to decompensate. We are all aware of the hypovolemic shock. I gave you an example. Trauma is a very common example, where we come in with patients who have bled a significant amount of blood, more than 20-30% of the blood volume. They come in with very dire situations. And you may also have a hypovolemia because non-hemorrhagic causes, for example GI losses. In our country, it is not uncommon to see a patient who comes in with 10, 20, 30 loose motions and vomiting and has severe hypovolemia, okay. And all you need to do is just correct the deficit and try and treat the cause of the volume loss from GI tract, and you would be more often than not correcting the problem. Obstructive, we only talk about tension pneumothorax and we only talk about tamponade in this, but an obstructive shock could very well be a pulmonary embolism as well, where you have a pulmonary vascular obstruction coming up. And then of course, you have the mixed variety. Mixed variety means you may have an overlapping situation, or there are some rare causes like cortisol deficiency, which may be an unknown thing, which may not be very easy to pick up in this syndromic things. So there are some things which are going to lie outside your syndromic approach, and you will have to sort of think out of the box that I am not really able to place this patient into any of those 4 quadrants. So where am I dealing with? And am I dealing with an overlap, or am I dealing with a completely different etiology? So you will have these metabolic causes of shock sometimes. As I said, compensated, decompensated and irreversible, okay. Now the important thing about compensated shock is that the patient is giving you time. The blood pressure is normal at that time usually, or lower end of the normal, but you will have the other subtle signs which you will have to pick up, and if you do not act upon that, the patient goes into a decompensation where the hypotension becomes, tissue perfusion worsens. Tissue perfusion may have already started worsening in the first stage itself. You have an altered level of consciousness, urine output starts dropping down. Urine output is like the intensivist of the body, it starts getting upset very quickly. If the kidneys are not very normal, you will have problems with the whole system. So it's like kidneys are the first alarm bells which you should be looking at. Cold peripheries, capillary refill goes down, and then if it reaches to an irreversible state, you have permanent organ damage, you have multi-organ dysfunction. All of us who work in a tertiary hospital are very well aware of patients who come to us with multi-organ dysfunction, and the only reason why they come to us in that situation is because they present late to a primary place, and obviously the primary place can only do so much. By the time they get referred to a tertiary hospital, the first 2 states of shocks have gone away. Okay. Now, if you ask me at the bedside what are my empiric criteria, where I would say that these are the things which I would think when the patient has got shock, these are some of the list of things, not necessarily a complete shopping list there, but obviously if a patient has got tachycardia, respiratory rate which is high or low, PCO2 which is going below 32, base excess, urine output, systolic blood pressure less than 90, I am going to start thinking of shock. Okay, I need more than one of those signs to be present to sort of start think of shock. Then there are certain important things. Level of consciousness, very, very important. Sometimes the patient presents only with altered level of consciousness, especially in elderly patients. In elderly patients, subtle sepsis should be picked up with level of consciousness changing, but level of consciousness may remain quite intact in young individuals, even when the mean arterial pressure goes as low as 30 or 40 millimeters of mercury. So it's not the best sign to pick up. There's something called a shock index. If your heart rate upon systolic blood pressure is less than 1, then you are in trouble. Okay, and your more than 0.9, then you are in trouble. And your lactate clearance index, I mean, as I said, lactate is something which is coming up. If your lactate is not getting decreased by more than 50% despite your resuscitation, and your lactate is greater than 4 millimoles per liter, then you are really in trouble, because you need to act very quickly. The important thing is diagnosis and treatment go hand in hand. First, clinical evaluation. Most important thing at the bedside for all trainees who are here, I am sure the physicians and the intensivists who are already trained know that, expose the patient with the cover for the patient's modesty. Okay, so try and have a look from head to toe, covering up the private parts of the patient, so that you have a good understanding of what is happening. Don't miss out subtle things. It happens very commonly in Maharashtra. I don't know about Hyderabad whether you actually see that, but scrub typhus is very, very endemic in the rural Maharashtra. I get a patient from rural Maharashtra. First thing I do is I take the clothes down, look at the patient, and around 20-30% of the patients we see that there is a iskar there. Okay, so scrub typhus is quite common there. So similarly, you need to look for all those things. Not uncommon to have a patient referred from the ward. Patient is having high INR and suddenly become hypotensive. When you undress the patient, there is a large lateroperitoneal hematoma which is sitting there, very, very tender, but nobody bothered to actually look at the back. And thus that the hematoma was not tracking anteriorly, was not tracking on the flanks. You just have to turn the patient and look at it. Auscultate, do your proper inspection, palpation and auscultation, percussion. Look at your cardiovascular system. Look for any new murmurs or new sounds, abdominal system. The clinical examination does not take away the clinical skills are so important that you should not be actually relying just on investigations to do the magic trick for you. Always remember, ask for either a PR or do a PR yourself. In our unit, all our intensivists do the PR if required, and the reason is that if you have a cause of shock, you should always think of a GI bleed. Targeted history. Initially, you may have a very quick history when the patient comes to you. Say the patient walks in from the emergency department to your hospital, to your IC, you may just want to know quick targeted things. But once the initial start have been settled down, then you need to know what the targeted history was. Was there a chest pain? Was there immunocompromised fever, medications? Is the patient chronically on steroids, hemorrhage, abdominal pain? All of those things are very, very important to know. There are 3 or 4 conditions which require a very quick fix. You don't have a lot of time to sort of go and have an approach towards it. And these are some of the things: anaphylaxis, tension pneumothorax, tamponade, and a severe trauma he presents to the resus room. Here you don't have to actually go through the syndromic diagnosis. You have a very, very obvious case which comes to you in front of you. Tension pneumothorax is a clinical diagnosis. Tamponade is again a clinical diagnosis confirmed by either an ultrasound or echo, and then you go ahead and treat that. Trauma is very, very obvious. Anaphylaxis, you will usually have some preceding thing, and the family will be able to tell you that this actually followed up after I ate this or after I took this medicine or something like that. So these 4 need a very quick approach. And then you go to your syndromic approach. You put up a patient on monitoring. Your cardiac monitoring needs to start off 2 wide bore cannulas. As soon as the cannulas go in, you start sucking out blood. Okay, you start sucking out blood for your blood test. The most important test which you can do here is either a venous blood gas or ABG. Most of the ABG machines now can give you a variety of things. Apart from just acid based blood gas and lactate, they will also give you electrolytes. Some of them will give you hemoglobin, hematocrit, will give you co-oximetries, a lot of things. Okay, last week we had a patient who was found unconscious in the bathroom, came in, carboxyhemoglobin was very, very high on the co-oximetry. Found out that she actually had a gas geyser in the house, and unfortunately the ventilation was not very well, and they basically had a carbon monoxide poisoning. Very well picked up by one of our emergency registers. Otherwise the PO2 was not that sort of obvious. The saturation was not coming up very well on the finger probe, but the PO2 was above 100 on the ABG. So very well picked up. We looked at the co-oximetry. The information is there. How often that we actually miss it out? We don't sort of put an effort to look into that. All the relevant investigations. So you don't need to put up a shopping list, but at least you need to have your relevant investigations ordered out. And arterial line, if you have 2 wide bore cannulas, next step of invasive procedure which you should do is an arterial line. Your CVP can wait for some time. CVP line is not necessary because we are not relying on CVP that much for your fluid resuscitation anyways. Then your approach is towards ECG, blood glucose, serum lactate. As I said, liver and renal function tests, coagulation profile if the history demands it, cardiac enzymes if the history demands it, and the chest X-ray. Lactate, remember there is a type A and type B lactic acidosis. It's not only about hypoperfusion. There are several other things which can produce lactate in our body as well. Medications which the patient may be on, disease states which the patient may be coming in with. Okay, so remember about lactic acidosis. Blood gas investigation, as I said, is the most important investigation which you may do, and you may have to repeat it to sort of follow up on what you are doing for your treatment. Glucose and electrolytes are very important to keep an eye on. Now, I am a fan of ultrasound. Okay, so I am going to actually talk about a little bit of 4 or 5 slides about point of care ultrasound, which should be a part of your approach. Without that, you cannot actually approach a patient in shock. And what you do is you do a variety of things. You do a left ventricular, right ventricular assessment, monitoring of the oxygen delivery by cardiac output, tamponade, obstruction. It depends on how well you are well versed and how trained you are in your ultrasound techniques. But you can do a variety of things, and these are some of the patients. The first view which our trainees are taught is a subcostal view. Subcostal view tells you whether the patient has got a tamponade or not, because the right ventricular free wall is seen very well. It also shows you the left ventricle quite well. So, the left ventricular function also comes into the picture. If you are a little bit more trained, you can put in a color Doppler here and you can see whether there are any regurgitant lesions or not. It is not very difficult to just eyeball and say that the top 2 pictures there do not have any other problem apart from left ventricular dysfunction. Okay, so there is a severe FLV problem, and the one on the bottom is just for the reference, it is normal. The one on the right hand corner of your screen is showing a severe right ventricular dysfunction. Okay, obviously the right ventricle is sort of distended so much that it has squashed the left ventricular completely. So, your approach towards shock immediately changes one picture, and it sort of helps you out of what is happening. Of course, it goes hand in hand with your lactate and all other things, but you have to have this sort of an approach there available with you. IVC assessment. I mean, now we have been talking for a decade almost that IVC assessment seems to be the most easiest way, non-invasive way to start doing fluid resuscitation to your patients. What is important is that if you have a IVC collapsibility, or in a ventilated patient IVC distensibility, at least some amount of fluid will be tolerated by the patient, because the IVC still has got some compliance remaining in it. So, 500 ml of fluid given is not going to cause a harm if a patient has got a change in the IVC diameter. Whether that will reflect to the increase in stroke volume or not is a different question which you may answer with your arterial line or your further echo evaluation. But if your IVC is changing diameter, feel free to give fluids. Obstructive shock can be easily found out. In my over last 17-18 years in intensive care, at least 17-18 patients in ICU I have found out that they were collapsed, and we put in a probe and we found out a pulmonary embolism. Out of which most of them had a cause for that, or they were in ICU. It was not like it was coming out of a blue as a surprise for us, and then we could treat them effectively. Some of them survived, some of them did not survive. This was a patient done a few years ago, where he came in with abdominal pain. The cause of his sepsis was gallbladder stones and gallbladder sepsis. This was a patient who came in with severe hypotension and pain in abdomen, and one of our registrars, this was around 2-3 years ago, actually did a probe, did an ultrasound of the abdomen just out of the sake, because he could not find anything else, and found a AAA rupture. Okay, so lot of things which we can sort of pick up. B lines, when you are doing fluid resuscitation, B lines is important. If you have crossed your B lines and the B lines start appearing which were not there before, stop your fluid resuscitation. If your B lines are there before, you know that my problem may be in the lungs. So, it all helps in both the directions. Pleural effusions, septated effusions, you know that you might be dealing with an empyema or some problem where it is originating from there. This is a hemoperitoneum in a traumatic patient who had come in with trauma, abdominal trauma, blunt abdominal trauma following a motorbike accident. So, again, no guesses, no stars. This is from emergency department I borrowed up, but this patient goes in for a laparotomy straight away. So, think syndrome, what syndrome am I dealing with? Am I dealing with a cardiac, trauma, etc. Correlate with your clinical findings, lactate, acid base, initiate more investigations or monitoring as required, repeat your ultrasound, repeat your EBGs again and again. Important is to establish airway quickly, hand in hand, as I said, it goes hand in hand. You can't sort of leave the treatment away. Control the work of breathing, assure adequate oxygen delivery, achieving endpoints of resuscitation. We've got a talk coming on endpoints of resuscitation, which I will sort of further elaborate on what it is. But the firm targets which will be seen will be, you have to look at the downstream indicators, the tissue perfusion indicators, maximizing oxygen, organ function, urine output, as I said, warm, peripheries, good blood pressure. All of these targets are very important. If you have a reversible etiology, very important to sort of try and target to reverse it, because unless you reverse the etiology, you will not have a resolution of the shock. IV fluids guided by echo, guided by dynamic indices, vasopressors as required, organ support as quickly as possible. So, in summary, go for a syndromic problem rather than just a cold hand and cold feet problem. Diagnosis and treatment obviously goes hand in hand. You can't leave the treatment going away while you are trying to diagnose it. One diagnosis is basic. Once the diagnosis is made, the aim is to try and reverse the etiology so that the shock resolution happens. And point of care ultrasound, I think, is mandatory when you have a treatment of shock going on. Thank you very much.